Good morning everyone. Today my topic is bone mineral density and periodontitis. So I will be talking about the bone mineral density and how it is intricately linked with the osteoporosis and osteopenia specifically, and how it is causing periodontitis in dentistry and how we can have the management plan. So coming to bone mineral density, the definition of it, bone mineral density is a measurement of the amount of mineral matter per square centimeter of bones, and how they and periodontitis is a chronic inflammatory disease causing progressive destruction of the tooth supporting apparatus, including the alveolar bone. Their study is essential for the early diagnosis, treatment, planning, and prevention of both systemic osteoporosis and oral health deterioration, which will happen when there is systemic BMD decrease and periodontitis in a person. So why it is necessary? Because they will share a common inflammatory pathway leading to alveolar bone loss, and the early identification of it can improve the prevention and the management of the systemic osteoporosis and in turn prevent the periodontal disease. This link also enables us to find interdisciplinary care among all the dental specialty cases, reducing the risk of both tooth loss and fractures for the risk of the populations. So coming to the details of bone mineral density, so I already discussed the definition, but primarily calcium and phosphate will be, the concentration of the calcium and the phosphate will be reduced in a specific volume of bone, which is expressed in gram per centimeter square. How we will determine whether the BMD has decreased or increased? Specifically, there are certain factors. First of all, it is a genetic factor. Up to 80% of the population genetically suffers from low BMD, and hormonal influence, specifically in women. The estrogen deficiency post-menopause accelerates the bone loss. The PDH hormone regulates the calcium. Also, the nutritional intake and the lifestyle of the person, specifically the intake of calcium and vitamin D in the form of D3 and other complexes, impair the mineralization. Also, the lifestyle factors, the sedentary lifestyle reduces the mechanical loading on the bone, and smoking and alcohol abuse also will impair the osteoblastic activity and in turn decrease the BMD. So diseases associated with low BMD, osteopenia, in this it is mildly decreased. It will not be classified into osteoporosis. It is a precursor of osteoporosis, osteopenia. Osteoporosis, on the second hand, is a significant decrease, increasing at fracture risk, and brittle bones will be there. The bones will be prone to fracture. And coming to the secondary osteoporosis, it will have systemic illnesses and conditions associated with comorbidities such as diabetes mellitus, rheumatoid arthritis. So how we can assess, how we can diagnose it actually? So through the scanning mechanisms such as dual energy X-ray absorptiometry, that is DEXA scan, gold standard. It is the gold standard and provides T-score and the Z-score for the BMD levels, and also quantitative computed tomography QCT. It is a 3D imaging procedure for but it includes higher radiation dose, so it is one of the cons of the procedure. And also this ultrasound in the third place, used for peripheral sites, specifically the heel region, limited accuracy compared to DEXA, which is the gold standard one. So now coming to the, sorry, yeah. So coming to the factors and how it is linked to periodontitis. So first, coming to the periodontitis definition, a biofilm associated post-mediated chronic inflammatory disease leading to the destruction of the periodontal ligament, cementum and the alveolar bone. Coming to the etiopathogenesis of the periodontitis, it will have bacterial plaque biofilm formation, which will trigger the inflammatory response, and the host immune response will have tissue damage via the cytokines, specifically the interleukin 1 beta and TNF alpha will come into play. Dysbiosis will be there, that is a imbalance between the pathogenic and the commensal bacteria, which is usually present in the oral cavity. So the risk factors, local poor oral hygiene, and the calculus deposition in the subside, specifically in the mandibular region. Also, the risk factors are for the systemic and comorbid conditions such as diabetes, smoking, and genetical susceptibility. Clinical features of the periodontitis are gingival swelling, redness, and bleeding for first of all, pocket formation in the second place, and clinical attachment loss subsequently. Progressive alveolar bone loss seen radiographically when we evaluate through the radiographs, and tooth mobility and loss in the advanced periodontal stage diseases. How we can diagnose? By clinical probing depth methods, probing depth and attachment loss, by radiographs to evaluate the horizontal and the vertical bone defects, and we can see for the biomarkers also, in which the increased MMPs will be there and rank L will be increased significantly. So how this periodontitis and BMD is linked? Pathophysiological link. Low BMD weakens the alveolar bone, making it more susceptible to the bacterial challenge, and then it will be having osteopenia first and then significant osteoporosis. And then we will have the brittle bones, and then the systemic conditions will come into play, and the advanced progression of the disease continues. Inflammatory cytokines are common to both osteoporosis and periodontitis that I already talked about, that is interleukin-6 and TNF-alpha. Estrogen deficiency in women, in post-menopausal women, correlates with periodontal bone loss. How we have this supporting evidence, how this pathophysiology inflammatory response is linked. Some recent literatures were done and research work in which then Tezen et al. In 2000 found lower BMD associated with increased periodontal destruction. Al-Habashman et al. In 2010 reported significant alveolar bone loss in osteoporotic women after menopause. And animal studies have demonstrated the experimental osteoporosis models leading to periodontal tissue destruction in the mice. And the confounders of the disease will be aging, smoking, systemic illness such as diabetes and hypertension, poor nutrition, and socio-economic status will also come into playing a role. So coming to the fifth mechanisms linking low BMD and periodontitis. What will happen exactly? What will be the pathophysiology? So osteoclastic activation will be there. Both diseases involve the upregulation of the osteoclastic bone resorption. Impaired osteoclastic activity will be seen in low BMD and periodontitis by reduced bone formation capacity. The rank L and the rank system and the OPG axis disruption will be there, in which the rank L promotes the osteoclastogenesis, and this decreased OPG, which will happen in turn, will fail to inhibit the rank L system, inhibiting the more bone reabsorption and the systemic inflammation. This in turn will lead to elevated CRP, that is an inflammatory marker, TNF-alpha. Both will be exacerbated, and it will lead to both systemic bone loss and local periodontal inflammation, and reduced bone regenerative capacity will be there in osteoporosis. Even after periodontal therapy, we have seen that alveolar bone healing is compromised, so adjuvant therapy is also needed. So coming to the management approaches and strategies for it. Management of periodontitis, we have it done in phases. Phase 1 will involve non-surgical periodontal therapy, that will be the first line of treatment, that is scaling and root planning. Phase 2, surgical interventions will be required. Advanced tissue procedures and guided tissue regeneration procedures can be needed. Host modulation therapy is the third phase. Use of sub-antimicrobial dose doxycycline to inhibit the MMLPs and significantly reduce the inflammatory markers. Management of low BMD, how we can do? Through pharmacotherapy. We will use the bisphosphonates. It will inhibit the osteoclast but pose a risk of medication-related osteonecrosis of the jaw in severe cases. We will also use the denosumab. It is a monoclonal antibody against RANKL, which will be producing inflammation in turn. We will use the SERMS, that is the raloxifene, and for post-menopausal women in the osteoporosis cases, and anabolic agents such as the teriparatide, which is a PTH analog, which will be used for controlling the PTH activity over enhanced PTH activity. We can also improve at the very first level by modifying our lifestyle modification, having less sedentary lifestyle and weight modification, weight bearing exercises, and also smoking cessation and alcohol stoppage should be there, and adequate calcium and vitamin D levels should be taken supplementally every day for the management of the osteoporosis and the osteopenia. So coming to the conclusion, what is there? There is a deep, clear bidirectional association between BMD and periodontitis, mediated by the inflammatory, immune and the hormonal pathways that I talked. Early diagnosis, interdisciplinary care management and preventive care are essential to manage patients at risk for both the BMD and the osteoporosis. Further longitudinal studies are also needed to classify causal relationships and to define the treatment protocols. Thank you so much.